With hyponatremia, hypo means under or low, and latremium is Latin for sodium, often written as Na+. And emia refers to the blood, so hyponatremia means a lower than normal concentration of sodium in the blood, generally below 135 milliequivalents per liter. The concentration of sodium depends on both sodium and water levels in the body. About 60% of our body weight comes from just water, and it basically sits in two places, or fluid compartments. A third of it is in the extracellular fluid, meaning outside the cells, and 2/3 of it is in the intracellular fluid, or inside cells. The extracellular fluid includes the fluid in blood vessels, lymphatic vessels, and the interstitial space, which is the space between cells that's filled with proteins and carbohydrates. Normally, the two compartments have the same osmolarity, which is the total solute concentration, and that lets water move freely between the two spaces. But the exact composition of the solutes differs quite a bit. The most common cation in the extracellular compartment is sodium, whereas in the intracellular compartment it's potassium and magnesium. The most common anion in the extracellular compartment is chloride, whereas in the intracellular compartment it's phosphate and negatively charged proteins. Of all of these, sodium is the ion that moves back and forth across cell membranes. And subtle changes in sodium concentration tilts the osmolarity balance in one direction or another, and that moves water as well. And this is why we say water follows sodium. That being said, hyponatremia, or low concentration of sodium in the extracellular fluid, and therefore the blood, can be caused by either losing more sodium than water, or gaining more water than sodium. Broadly speaking, hyponatremia can be divided into three categories, based on water volume status. The first is hypervolemic hyponatremia, where there's a huge increase in total body water, and only a small increase in total body sodium. So in this case, you're gaining more water than you are sodium. Typically, this is seen in conditions like congestive heart failure, cirrhosis, or nephrotic syndrome, where a ton of fluid leaks out of the blood vessels and into the interstitial space, and this causes edema, especially in the ankles. Even though there's more water overall, there's a decrease in the effective circulating volume, which is the amount of blood flowing in the body. That, though, stimulates the release of antidiuretic hormone, which retains pure water, leading to an increase in water, and it also stimulates the release of aldosterone, which retains a little sodium. But remember that since water follows sodium, the body ends up retaining even more water as well. So ultimately, you can see that there's a large increase in water, but only a small increase in sodium. And this leads to hyponatremia. The second category is hypovolemic hyponatremia, where there's a small decrease in total body water and a large decrease in total body sodium. In other words, you're losing more sodium than you are water. This can happen in conditions like diarrhea or vomiting, where the cells lining the gastrointestinal tract actually pump sodium ions into the digestive juices, but then those ions don't get reabsorbed because the undigested food and the digestive juices are just tossed from the body. It can also happen in response to using certain medications, like diuretics, where sodium ions are pumped into the renal tubule and then lost in the urine. Another more nuanced condition is cerebral salt wasting, which is when an intracranial injury like meningitis disrupts the normal sympathetic nervous system stimulation of the kidneys, and this leads to disproportionate loss of sodium. A third category is euvolemic hyponatremia, also known as normal volume hypovolemia. And this is where there's a normal body sodium, but an increase in total body water, even though that's sort of contrary to the name. The reason that it's given this name is that you don't have fluid pouring into the interstitial space, and therefore there's no edema, and so no clinical signs of hypervolemia. Euvolemic hyponatremia can be split into cases with dilute urine and concentrated urine. Cases that cause dilute urine include adrenal insufficiency, hypothyroidism, and drinking too much water, called polydipsia, as well as drinking too much beer, which is called potomania. Basically, here the body has a lot of water and the kidneys are trying to get rid of it as best they can. The main condition that causes concentrated urine, on the other hand, is syndrome of inappropriate antidiuretic hormone secretion, which can be shortened to just SIADH. This is where inappropriate presence of antidiuretic hormone causes water retention, which ends up meaning the urine gets more concentrated. Now, there's one final type of hyponatremia, and it's sometimes called a false hyponatremia or pseudo-hyponatremia. This is where the body water and sodium levels are normal, but there's an excess amount of lipids, like in hypertriglyceridemia, or there's an excessive amount of proteins, like in multiple myeloma. High levels of lipids and proteins affects the laboratory instruments that measure the sodium concentration, and this makes the instruments say that the sodium concentration is too low, which is false. Hyponatremia can cause symptoms like nausea, vomiting, and muscle cramps. In severe hyponatremia, which is when the sodium concentration falls below 120 milliequivalents per liter, there can be cerebral edema, which can cause confusion, coma, and even death. The cerebral edema results from water shifting from the extracellular compartment to the intracellular compartment, causing the cells in the central nervous system to swell up and get damaged or die. It can also cause increased intracranial pressure, which can squash the blood vessels heading in and out of the brain, causing ischemia, as well as possible brain herniation, which can damage the respiratory centers in the brain and cause respiratory failure. Hyponatremia is usually diagnosed by looking at physical exam findings, as well as labs from the urine and blood. For example, a normal serum osmolality suggests true hyponatremia, versus a pseudo-hyponatremia. In addition, signs of edema suggest hypervolemic hyponatremia, whereas signs of dehydration suggest hypovolemic hyponatremia. Also, urine osmolality can help differentiate between the two types of euvolemic hyponatremia. If the urine osmolality is really concentrated, greater than 100 milliosmoles per kilogram, then the problem might be SIADH. On the other hand, if the urine osmolality is dilute, less than 100 milliosmoles per kilogram, then the problem might be due to taking in too much fluid. The urinary sodium concentration can also be helpful, with greater than 20 to 40 milliequivalents per liter suggesting SIADH and cerebral salt wasting, and less than 20 milliequivalents per liter suggesting hypovolemia. Treatment of hyponatremia depends on the underlying cause. In patients with SIADH, fluid restriction is generally first-line therapy. On the other hand, if patients are hypovolemic, giving more fluid can be helpful. Generally speaking, for severe hyponatremia, it's important to give hypertonic saline, but this has to be done really carefully to avoid complications like cerebral pontine myelinolysis, which is where there's a loss of myelin in the pons, which is a structure in the brain, and this is due to rapid shifts in sodium and water. Alright, as a quick recap, hyponatremia is an electrolyte disorder that describes a low concentration of sodium in the blood, which can be divided into hypervolemic, hypovolemic, and euvolemic causes. Euvolemic can be further split into those with concentrated urine and those with dilute urine. Hyponatremia can cause water to shift into cells, and in severe cases it can lead to cerebral edema and death. Increasing sodium levels can be done with hypertonic saline, but needs to be done slowly to avoid cerebral pontine myelinolysis.